Thank you very much for that very kind introduction. And we are hoping to have a glitch-free morning. So this is the perfect segue. The previous talk, Mauricio did an excellent job of setting up why we need to think more about neuroprotection. So you learned two things in the last hour that are very important. Time is brain, which we already knew, but for whatever reason we weren't using time is brain in intra-arterial. And the previous studies failed and the modern trials succeeded because they got the artery open quicker. Time is brain. The artery needs to be open quicker. And the second thing you learned is what Dr. Concha finished up with, which is not everybody gets better. Even if you have the perfect door to needle time, get the artery open, not everybody gets better. So we need something more. We need a neuroprotection. And at the end of this hour, I hope you will believe hypothermia is the right thing to test next. So why do we believe in hypothermia? Hypothermia works in cardiac arrest. Let's look at that data. This is data from a study that is called the Hypothermia After Cardiac Arrest Study, HACA. And in the HACA study, this is temperature along the y-axis and time along the x-axis. And it shows you the temperatures in the two groups. And you notice that the cooled group, and remember these were randomly assigned, the cooled group got down to 34 degrees around 6 hours. They did a little glitch right here, but it was about 6 hours that the patients finally got to target, which is pretty long. That's pretty long for cardiac arrest. But look at the normothermia patients. The patients assigned to normothermia were pretty warm. I mean, there's got to be a few fevers in here pulling the average up, right? So in the HACA study, they compared aggressive hypothermia to really no management of temperature, no temperature management. They did try to treat fevers with surface pads and some Tylenol, but this was a pretty warm group compared to a very cold group, and they found a highly significant benefit. Blue is good. Normothermia 39%, hypothermia 55%. This is good outcome in the HACA study. And this was a first. Cardiac arrest victims routinely died. And with the advent of defibrillators in the field, bystander CPR, and aggressive hypothermia, cardiac arrest now, many patients, people in this room have cared for, people that go home without any neurological deficit after an in-the-field cardiac arrest. Here's the mortality curve in the HACA study. This is death. So the death is much less in the hypothermia group compared to the normothermia group. But it's not only death that we improve, it's that function. The patients go home functional. And then this is the Australian study, which was published at the same time as the HACA study. The Australian study had only 34 patients in the normothermia group and 43 patients in the cooled group. And yet it was statistically significant. The blue is good, 26% versus 49% in a small study. Now, one of the big differences, time is brain. And in the Australian study, patients got to target on average sooner than they did in the HACA study. And then mortality was also, mortality was not as different in the Australian study because of the small sample size. Then what happened? How many of you have heard of the TTM study? All right, so not everybody's involved in cardiac arrest here. So let me explain what happened here. The TTM study is therapeutic temperature management study. And these investigators set out to see if 36 degrees of hypothermia was different than 33 degrees of hypothermia. So they're comparing two groups of cooling. And you can see they did sort of a good job. Their patients got to 33 at random or 36. There's a couple differences from the HACA study that I showed you before. Does anybody see those differences? First of all, they didn't get cold until about 8 or 9 hours. So they didn't get to target that fast. Time is brain. You're not going to help if you get to target later. And second of all, this is not the same control group as in the HACA or the Australian study. This is a cooled group. This is a temperature managed group. These people were being actively cooled. So you're comparing two types of cooling, all right? And there was no difference. There was no difference when they compared 33 to 36 in the TTM study. So you will hear, now that you're tuned in to listening for this, you will hear cardiologists, intensivists, and ED physicians tell you therapeutic hypothermia doesn't work. It doesn't work. Look at this. The TTM study showed it doesn't work. Well, that's wrong. Of course it works. It worked in the HACA study. It worked in the Australia study. It works. You've seen it work many times. How do we explain the differences here? So how we explain this is we go back to the lab and we try to figure out what went wrong. Why did the TTM study fail? So of course you assemble your group of ace investigators and you take them out fishing to get ready for this job that we're going to do together. And we cultured brain cells. So the brain has neurons, astrocytes, endothelial cells, and so you grow up in a dish, a culture of each of those types of cells, neurons, astrocytes, and endothelial cells. How do you simulate cardiac arrest in a dish? Turn off the oxygen, take out the glucose. That's basically what cardiac arrest is to the brain. Take out the glucose, take out the oxygen. It's very simple to do. Actually, it's very, I shouldn't say that. This is a very hard thing to do, and this young man right here is an absolute genius. He's a very gifted experimentalist at doing these kinds of work. So you take the neurons and you turn off the oxygen and glucose for 2 hours. That will kill 80% of the cells. Then you turn off the oxygen and glucose for 6 hours. I made a mistake on the slide. And you'll kill 80% of the astrocytes. And if you turn off the oxygen and glucose for 10 hours, you'll kill off 80% of the endothelial cells. So it's stroke in a dish, or cardiac arrest in a dish, for the 3 most important types of cells in the brain. But it's a little tricky, because you have to turn off the oxygen and glucose for different times for each of the 3 cell types. Then you take the dish out of the incubator, and you put it in a 33-degree incubator or a 35-degree incubator. And then you wait, and after 24 hours, you count how many cells have survived. So it's a very simple design, and this is a schematic of how we put it all together. You do the cardiac arrest, the OGD, and it could be 2, 6, or 10 hours, depending on whatever cell you're doing. And then you put the oxygen and the glucose back. You restore circulation. So think of this as being ROSC in a dish, right here. This is when blood flow is restored, all right? And then you cool for a couple hours, but let's see if maybe cooling longer works, or maybe even 24 hours of cooling. So we're testing different amounts of cooling after the ROSC in a dish. Or you delay it. Maybe it's a 30-minute delay after ROSC before cooling. Or maybe it's a 60-minute, or maybe a 90-minute delay. Because we're curious, what happened, because TTM was 9 hours, HACA was 6 hours. So maybe we can simulate some of that delay problem. So we're studying the depth of hypothermia, 33 or 35 or normal. We're studying the delay, and we're studying the duration, to try to tie the story together and understand what went wrong in the clinical trials. Now, it's important that we do study all 3 types of brain cells. This is a sketch. This is a capillary in the brain. This is the blood-brain barrier. It consists of these endothelial cells, and this is a red blood cell blocking up the artery. There's pericytes. These are the astrocyte foot processes sticking on the endothelial cell. And these are white blood cells now escaping out of the broken blood-brain barrier during the stroke. So it just shows you how the different 3 cell types play together, the endothelial cells, the astrocytes, and the neurons that are standing by. Now in red are some of the different chemical reactions that happen, not the point of our talk today, except to say that hypothermia reduces all of this. Okay? Hypothermia suppresses oxidative stress. It prevents the swelling of the astrocyte. It prevents the leukocyte from releasing these chemokines here. It prevents platelet activation, and it prevents, most importantly, neuronal apoptosis and necrosis. So here's how it turned out. It was actually a really interesting experiment. So on the left-hand side, we have no delay. These are our neurons. And remember, for neurons, you have to turn off the oxygen glucose for 2 hours. If you don't delay, if you immediately start hypothermia, as soon as you get ROSC in the dish, 100% of cells with no OGD at all, these are just the controls, they're just sitting there walking down the street with no VFib at all, that's 100% survival. Normothermia, you kill 80% of them. All right, so this is an internal control. The system works. 80% of the cells die without any hypothermia. If you cool them for 2 hours, 33 gives you better survival than 35. But the difference here, it's highly statistically significant. 33 is significantly better than 35. But look at the size of the effect. Although it's a significant effect, it's smaller than the difference between normothermia and any cooling. See that? The delta here is huge. The delta here is significant, but not as big. All right? It's only about 1/4 of the effect size of this right here. Now, if I cool for 6 hours, I get a little bit better result. Cooling longer is better. These bars are statistically significantly different. And that's true for the 35 as well. And then here's 24-hour coolings. So cooling longer is better. Cooling deeper is better when there's no delay. Okay? Well, what about when there's a delay? And we did a lot of this. I'm only going to show you the 90 minutes. So here's the 90-minute delay. If I wait an hour and a half, I get ROSC in a dish, I let those cells sit there for a while, and 90 minutes later I start hypothermia. 2 hours of hypothermia does not work. So whereas 2 hours worked if I started right away, if I wait 90 minutes, no effect. So there's an interaction between delay and duration. It's almost as if you delay too long, then you need to cool longer to get benefit. And that's shown here. 6 hours and 24 hours worked, all right? In fact, 24 hours of cooling at 33 was almost as good as if there was no delay at all. So it's almost like I could make up for the delay by cooling longer. But again, 33 is better than 35. There's still a duration effect in the 35. It's still true that longer is better with the 35. But the 33 is always better than 35, no matter what the delay, no matter what the duration. How about the astrocytes? Same phenomenon, all right? 100% survival in the unstroked, unarrested cells, 80% cell death with normothermia, 33, significant benefit. Now in the astrocytes, it's interesting, 33 is way better than 35. But 6 hours, the 35 catches up. 24 hours, the 35 catches up. So in the astrocytes, 33 is much better than 35. Until I start delaying. So here's the 90-minute delay. 33, 35. So I've still got my duration effect. Longer's better. I've still got my depth effect. 33 is better. And I've still got my delay duration interaction. The longer you wait to start, the longer you have to cool. So now I've shown it with neurons and astrocytes. The endothelial cells got really complicated on us. We were hoping that it would be a simple story. There is still, this is the no delay and this is the 90-minute delay, there is still a duration effect. So duration is still there. There is still a delay effect. So 90 minutes, not as good. And there's still a depth effect. So the difference between 33 and 35 is still there. But there's a little problem. Does anybody see it? So this is no stroke, 100%. I've actually got more endothelial cells with cooling. So the hypothermia turned on something, which we don't know. They think it's funny too. The hypothermia turned on something that makes more endothelial cells. And we're just trying to understand the molecular biology of what that possibly could be. And we think we have some ideas. But even though it's more complicated, the lessons are there. So I've summarized the lessons in this chart, which shows the difference between 33 take away 37. So 30, and the 33 is shown in yellow, and the 35 is shown in black, and the delay time is shown here. So these are my delay times, 30, 60, 90, and these are my treatment durations, 2, 6, and 24 hours. So I've got all those data that I just showed you summarized into one map, if you will. It's a depth, delay, duration map. And it shows, for example, here, at 0 delay and 2 hours of hypothermia, I get about a 36% betterment over normothermia with the 35 versus a 52% betterment with 33. So whereas 33 is 53% better, 35 is 48% better. And at every stop along the way, everywhere, 33 is always a little bit better than 35, regardless of delay, regardless of duration. So that delay duration effect is mapped out here, but the map clearly shows that 33 is always better than 35. So now we know why TTM failed. TTM failed because they were trying to compare this versus this. All right? The other studies were comparing both maps versus the floor versus normothermia. Well, look at that gap. That's a huge gap. That's easy to show. Australia, 34 patients versus 43 patients. They showed a statistically significant difference because they're comparing the maps up here to the bottom. That's a big difference. You don't need a lot of patients to show that. How many patients do you need to show penicillin works for pneumococcal pneumonia? Basically 2, right? One with placebo, one with penicillin, you're done. You know the penicillin works for pneumococcal pneumonia. So how many patients do you need to show a difference for therapeutic hypothermia versus normothermia? 40, 50, 100. How many patients do you need to show a difference between these two maps? It works out that you need about 800 patients. And TTM had about 400 patients. So they just missed it. They just missed it. The effect has to be in there, but they missed it. So the next time somebody says to you, we don't need to cool this patient, this cardiac arrest survivor, we don't need to cool them because hypothermia doesn't work, you say type 2 error. Type 2 error. That's the statistical term for when I didn't do enough patients. It's a type 2 error. And they'll look at you kind of funny, but make them cool the patient. All right, so let's talk quickly about MI, because hypothermia has not worked as well for myocardial infarction. And this is a reanalysis of a study called COOL-MI. And in COOL-MI, they tried to get MI patients to 33 degrees and try to show a benefit. And when they compared outcomes, which was infarct size, looking at all of the cooled patients versus all of the controls, there was no difference. They had an 18% outcome in the treated group and 18% outcome in the control group. So this was published, and people said hypothermia doesn't work for MI. And then this experiment was done in a pig model where they got the pigs cold before they reperfused. So they got the temperature down to target before they opened the artery. And look at this, white is bad. So in the control group, big infarct. In the hypothermia group, less infarct, highly statistically significant. So then they went back and they reanalyzed the COOL-MI study for those patients who were less than 35 before the balloon went up and the artery was opened compared to those that were greater than 35. And you can see if the patient was cold before they opened up the artery, they cut down the stroke volume to 9% versus the patients that were over that target, 21%. So they missed the effect because the patient needed to be cold before they recanalized the artery. And then this was confirmed in a reanalysis of the ICTUS study. Same type of story, same failure. When they checked the temperature, they got a 12% versus a 22% significant reduction in stroke size when they reanalyzed the patient's temperature at PCI less than 35. That was the group that did well. So a final study was done to try to prove this, to try to show that this was actually the explanation. And it took them a little while to get the patient to target temperature, but when they used cold saline plus endovascular cooling, they got the patient to target in about 5 minutes, which is good. And this was the result on the primary analysis of, this is their pilot study, the CHILL-MI pilot study. So it's a small number of patients, but they looked at troponin, statistically significant result, and they looked at infarct size, statistically significant result. So that was promising, and they launched the main trial, CHILL-MI, the main trial, and a little bit of a problem. So this is the temperature in the cooled group at the time the wire went across the lesion. And this is the temperature at the end of cooling. So you can see the patients were not quite cold enough at the time they were just about to put up the balloon. They were almost there, but not quite. So this is the main result. Looking at the stroke size is smaller in the hypothermia group, but it's not statistically significant. They got about a 13% reduction in stroke size, but it wasn't quite statistically significant. And the reason is explained here. When you look at the anterior wall only, you get a statistically significant result. But when you look at the posterior, or the inferior STEMIs, you don't see the difference. So when you sum that together, you lose the result. So when this happens in clinical medicine, when something goes wrong again and again, and each time you say, well, I know what happened, I just got to fix that, you begin to doubt a little bit that this is actually going to work out in the long run. But when they looked at death and heart failure, they had a very big difference in the number of patients who died or were left with, clinically significant heart failure. So, and this is statistically significant, and this was a primary endpoint. So it was positive. There is an effect, but it's tricky. It works best in anterior wall, and it works really only if you get the patient cold before you open up the artery. So finally, let's update on the status of the stroke study. So just to restate, these are the different things that go wrong in the brain during a stroke. Glutamate is released, and I know some of you may remember the old glutamate antagonist trials that we did for stroke. That didn't work. Potassium is released from the cells, which causes more glutamate. Mitochondria are damaged. That damages the DNA. Tons of free radicals are generated, which activates microglia and other white cells. And again, hypothermia acts at 1, 2, 3, 4, 5, 6, multiple steps. It's a multimodal neuroprotectant. This is the main picture to remember about stroke. If you go home with any picture in your mind, this is the picture to remember. White is bad, red is good. 33 versus 38. A lot of white, less white. So powerfully, regardless of mechanism, neuroprotection with hypothermia is a powerful, powerful treatment. In fact, it's so powerful, and there's been so many studies, these investigators did a meta-analysis. I know you see a lot of meta-analyses for drugs that prevent stroke or for prevent other things. And in a meta-analysis, you take all the papers and you try to find something to compare them. You know, you're usually comparing apples and Toyotas, but you try to find something that you can link between all the studies. And that's the size of the treatment effect. Remember, we were looking at the treatment effect when we did our depth, duration, delay curve. We were looking at the treatment effect. That's the amount of cells that survive in one treatment versus the other. That's the treatment effect. So all of these studies, and there were 101 studies, had a different measure. It might have been the size of the white on that pink stain. That's what it was in most of these. It might have been something else, like function. But whatever it was, they computed the treatment effect due to the hypothermia. And look at what they got. The gray band is the average of everything that they studied, and it's about a 45% treatment effect. That's ginormous. That's huge. That means they could shrink the strokes by 45%, study after study, across all sorts of different models and species. And what's also kind of interesting here is look at the depth effect, 35, 34, 33, 32, 30. Definitely a bigger treatment effect size with colder temperatures. Deeper is better, which we learned in the cardiac arrest in a dish data. It's also true in focal stroke. These are the clinical studies that have been done already. And the table shows the name, the amount of patients, the target temperature, how long they treated. I'm sorry, this is delay, this is duration, this is how they cooled, and this is the pneumonia rate. So without knowing what I just told you about the relationship between depth, duration, and delay, each of us who designed a study here picked arbitrarily a maximum delay time and a treatment duration without really knowing if that made any sense. So keep that in mind when I tell you the number of patients here is on the small side. All right, ICTUS L is right here. That's 28 patients. That's a pretty big study. And ICTUS Pilot is right here, 18 patients. So ICTUS L was the most recently published trial, and it happens to be one of the largest. ICTUS L used this catheter right here. This is called the Accutrol catheter. It's made by Intercool. And we will be using the Zoll catheter, which is the system is called Thermogard. The catheter might be the Quattro, the IC, or the Cool line. These catheters go into the inferior vena cava. They're easy to put in. You put them in aseptically. You don't necessarily need fluoro, but after it's in, you do a KUB to check the placement. And some days this runs and some days it doesn't. Here we are. This is a catheter going into the IVC. And what we're doing is endovascular cooling. We're cooling the patient from inside out. So the patient's own heart pumps cool blood throughout the body. The IVC blood is cool. It enters the heart. Heart pumps it throughout the entire body. So you're cooling the patient from inside out. No pads. This allows you to put a warming blanket on the skin, which fools the brain into thinking, I'm warm, I'm not cold. Your sensation of cold is in your skin primarily. There are some internal receptors as well. The device, once it's in the bloodstream, is chilled to 4 degrees. It goes in over both of them, both the ICTUS and the Intercool go in over a wire, and then this metal shaft here transfers heat through these bevels. The blood is mixed, so even though the blood right on the surface of the catheter is 4 degrees, it's mixed in the IVC. So the blood is actually 10 degrees or so when it hits the heart. This is a little schematic of how the balloons in the ICTUS product transfer blood. Now, the whole secret to cooling a patient who's awake, your cardiac arrest patient is paralyzed and intubated. Your MI patient is probably paralyzed and intubated. Your stroke patient, at least for a while, is wide awake. And we want to cool them without paralyzing them or intubating. So how do we keep them comfortable? We use a trick that's fairly unique to meperidine, IV Demerol. So we have a graph here that shows the concentration of meperidine in the blood versus the threshold at which people shiver. All right? Most people will start to shiver around 35.5. Our colleagues in Boston shiver at a slightly higher temperature. Me and you may be slightly lower, but this is the shivering threshold being lowered with increasing amounts of meperidine. So the more meperidine, the more cold you can tolerate without shivering. Now right about here, the patient starts to breathe less. So right about here, we can't go any higher on the meperidine. We have to stop, and that gets us to about 34 degrees. So we can reach a target of 34 with a very gentle meperidine drip without any respiratory suppression whatsoever. And Dr. Concha has done this many times. I've done this many times. Either one of us can give you the details, but it's a very simple thing to do once the patient's in your unit. To get from 34 to 33, you need to add buspirone. It's an oral drug, and it does synergistically work with the meperidine to get you to 33. Plus, you put that skin warming blanket, surface counter warming, to manipulate the temperature receptors. When you do all three, titrate the meperidine, give the buspirone, warm the skin, you can get the patient to 33 degrees. This is our study called ICTUS-L, which I showed you had 28 patients in it. And we learned that we could do this endovascular cooling in awake patients, and we could combine it with TPA. There's a lot of hesitation to be jamming catheters into patients who are getting IV TPA, but we showed that it was safe. We did have some SAEs. We did have some serious adverse events, mainly pneumonia, but the pneumonia did not affect the outcome at 90 days. So that was our ICTUS-L study, the pilot feasibility study. This is a patient from that study. His temperature is over here. The minutes of cooling is over here. 34 is our target. Actually, our target's 33, but you draw the line at 34 because 33.9 is 33. It's at target. So you want any temperature of 33, whether it's 33.0 or 33.9, you draw the line at 34. So if I say the area under the curve, the amount of time he spent below 34, what I mean by that is the amount of time at 33. And this patient cooled right down, stayed below there, and then when it came time to warm him up, we warmed him up. So he's 90%, his AUC below is 90%. 90% of his time he was below the limit. As opposed to this patient who went down there, bounced up, and then was very difficult to take care of. So we tried to understand why is it so hard to cool some patients and not others. And we analyzed the age and the weight, the gender, the shivering score, the meperidine, the buspirone. And then we tried to figure out how did that influence time to target, AUC 34, which remember that means how much time they're at 33 degrees. And for comparison, AUC 35, because how much time they're at 33 or 34. And this is every patient in ICTUS-L who got cold. And along the top axis here is how long it took to get cold, so not long. And then their weights are shown along the bottom. And you can see by the general shape of the curve, these numbers here are the temperature at their lowest temperature and also their first temperature below 34. And you can see from the shape of the curve, most patients get cooled. This works most of the time. These two over here took forever to get cold. They didn't get the buspirone. They didn't get the buspirone. In one case, the investigator said, I don't want to give it. And in the other case, the patient vomited up and they didn't replace it. But both patients didn't get their buspirone. So if you do everything right, you basically can get patients to target pretty fast. What influences time to target? Age. So the older patients cool quicker. The little old patients cool more quickly. And then weight. The bigger patients cool slowly. So it's all about transferring heat. And with the catheters that we use today, bigger patients are harder to cool. And then Demerol. So using the meperidine well, titrating it aggressively, got you to target quicker. Those are and this is true for cardiac arrest, by the way. Older cools quicker, heavier cools more slowly, and then using the Demerol helps. This is the determinants of AUC under 34, so keeping them there. Once they're there, how do you keep them there? Age wasn't so important, but body surface area was huge. Body surface area was very important, and then managing the meperidine drip. And the same result we got for AUC 35. And then the pneumonia. I told you that in ICTUS-L a lot of patients got pneumonia, and we really couldn't find anything that explained why those patients got pneumonia. So as it turns out, the probable definition of the probable reason for the higher rates of pneumonia in ICTUS-L was a definition. We didn't tell the investigators how to assess pneumonia. So imagine this trial. If you randomize to normothermia, good luck. See you later. We're going to do an assessment in 30 days. If you randomize to hypothermia, the team came in and we were at the bedside for 48 hours straight, put in the catheter, titrate to Demerol, we're watching you, and nothing happens. We're sitting there. We're all highly trained investigators waiting for something to happen. Oh, the patient coughed. Get an x-ray. Oh, there's white. It's pneumonia. Versus the normothermias that nobody's seeing. So this, because we couldn't find any determinants of pneumonia, it suggests strongly that there's a case selection bias, case ascertainment bias. So we're testing that hypothesis in a second. So basic conclusions: time to reach target is a function of age, weight, and shivering control. Maintaining depends on weight, but not so much on shivering control. All right, so as Dr. Concha mentioned in the introduction, we are doing a study called ICTUS-2, ICTUS-3. The methods were published, and basically we need about 1,200 patients to detect we're looking for a 7% treatment effect size. 7% treatment effect. I showed you in the animal meta-analysis a 45% treatment effect. And this is our plan. We're in the ICTUS-2 phase. We've actually finished, and we're trying to transition to ICTUS-3, and we're changing funding. We were funded before by something called Spatrius. Now we're changing to a U01. The purpose is to determine whether the combination of thrombolysis and hypothermia is superior to thrombolysis alone. And it's a prospective, randomized, blinded study, and the outcome is that 90-day Rankin score. You learned a lot about Rankin scores during Dr. Concha's talk about intra-arterial therapy, and we're looking for the same outcomes in this study. We wanted to know, ICTUS-2 used a bolus of ice saline. We combined, we started giving a liter of cold saline, actually 2 liters of cold saline. And we noticed that nothing was really happening. So we decided to compare the first 41 patients in ICTUS-2 to 26 patients from ICTUS-L, and to see if the bolus was working, because in ICTUS-L we didn't do a bolus. And the groups were well matched in terms of gender, racial distribution, incidence of diabetes, and hypertension. So it was a fair comparison. Age, weights were comparable, but heights, actually weights were slightly different. The patients were slightly heavier in ICTUS-2. So these are the temperatures at 1 hour, 2 hours, 4 hours, and 6 hours. So you can see that giving 2 liters of ice saline to stroke patients before you put in the catheter did not get you to target more quickly. We were hoping it would. There's a couple problems with this. We don't know how long it took to get the ice saline into the patient. We don't know if it was open, wide open in every patient, or dripped it in over a couple of days, or what they did. So, side note, cardiac arrest, full court press, big arteries, big gauge IVs, throw in a couple liters. Stroke patients, little old lady, 22 gauge needles, everything's on the pump. So yeah, it takes a couple days to get 2 liters in that way. So where are we at? We have 120 patients enrolled in the ICTUS 2 study, which, as you remember from that slide I show you of all the trials, this is the largest trial of therapeutic hypothermia ever done. We decided to close it because of the data that Dr. Concha just showed you. So because of all that intra-arterial data that's showing all this new excitement about how to open these arteries, we had to stretch our protocol to include that, and we just couldn't do it. We couldn't stretch our protocol to allow that new technology and still have the same protocol that we had before. So we decided to just close it early, wrap it up, look at the data, and redesign ICTUS 3 to include the intra-arterial therapy. So data is locked actually on Friday, last Friday. So, and I want to thank Dr. Concha and his team for helping us close their site and get their data locked on time. And all of our sites are now locked, and the analysis is underway. So a couple of things I think we'll do in ICTUS 3. We'll probably eliminate the saline bolus. We're definitely going to simplify the protocol, make it much easier. We're going to add intra-arterial therapy. Still working on how that's going to be done. We are working with Dr. Tudor Joven, who was one of the PIs of 2 of those trials that Dr. Concha showed you. We're going to add sites. And then we're proposing the trial to the Stroke Net. The Stroke Net is a new business funded by the NIH to do stroke trials in America in an organized way. So they have a central coordinating center, a central database, a DSMB, and a central IRB. So if your site joins a trial in StrokeNet, it won't go through your IRB. It'll be reviewed by this central IRB. And then they have some steering committees and whatnot, and some core groups and advisory committees. So the point is we should be able to roll the study out more quickly because the infrastructure exists to do the study. So we have proposed our study to NIH. It's been reviewed once very favorably. They simply want to see more details about the intra-arterial part of the business. And we should hear from them maybe around the first of the year, maybe early 2016, as to whether we're going to get the green light to continue. In the meantime, you will hear the results of ICTUS 2. We'll certainly publish that. And you'll hear the results of that ROSC in a dish that I showed you. Plus, we have a few other animal studies in the lab to try to tease out more about this depth, duration, delay effect. So it's, again, a real honor for me, and you can see why. I need to tell people the story about TTM and about where hypothermia is going. And the next time someone says to you therapeutic hypothermia doesn't work, you're going to say type 2 error. Great. Thank you very much. I appreciate it. I'd be happy to answer any questions if we have time. Is there time? Yep. Yeah, in the back.
What is the number needed to treat of patients that to show that hypothermia is a benefit?
So if we stick with the 7% treatment effect in ICTUS 2, we need 1,600 patients. But
To show benefit for what?
the sample size would be 1,600. What we're intending to do is to change that treatment effect to 12%, because the animal data suggests we should be looking for a much bigger benefit. That will reduce the sample size down to somewhere around 700. A 12.5% treatment effect, I can never do this in my head, works out to a number needed to treat of 8-ish, 8 to 10. So it's not as magic as intra-arterial, but you know, you have numbers needed to treat for Coumadin for AFib of 50, and we all do that. So about 8-ish. Yes, ma'am.
Select your patients Is it like all of the stroke patients?
Yeah, the selection criteria for ICTUS were very, very tight. For ICTUS 3, it will be much broader. The NIHSS will have to be above 7, but that's it. It'll be open to anterior circulation strokes of any type of, and then they have to get TPA, so they have to be within 3 or 4.5 hours. Yes, sir.
Your data seems to suggest that 33 degrees Celsius performs somewhat better than 35. What are the perils of 32 or 31 degrees?
It's an excellent question. One of the experts in this area has opined that if you drive the patient through the shivering down to 32, that the shivering will stop. Few of us have actually attempted this, but he's insistent that this might work. I think that's more in intubated patients. But in any event, most of the complications that you see with hypothermia occur below 32. And remember, when someone says to you, oh, hypothermia causes coagulopathy, pancreatitis, that's in accidental hypothermia. That's in patients who are sunk in the lake, or they're a trauma victim in the snow. They have a lot wrong with them besides the accidental hypothermia. But even in accidental hypothermia, if you keep above 33, you don't have coagulopathy. Coagulopathy's never been reported over 33. Your platelets function, you don't get the pancreatitis, you don't get the liver enzyme elevations. So below 33, below 32, really, that's where things start to go wrong. Okay. All right. Thank you very much.